First, let me start off by saying here's the CME code 15430. I'll say more about that in just a few seconds. These virtual ethics rounds are put on by the Ethical Advisory Committee, and just want to say a few words about the Ethics Committee. We're a 24/7 consultation service, and the best way to contact us is either by calling my cell phone number or place an order in Epic or Tiger Connect Me as well. This presentation is offering 1 CME credit, and to obtain your CME credit, the code for today is 15430. Put that in the Cloud CME app on your phone or your iPad, or you could send me an email today saying that you attended today's session. So the objectives of this activity is that participants should be able to discuss ethical dilemmas in clinical practice and explain how to use an ethical framework for solving ethical dilemmas. And these presentations are being taped. If you say something that you didn't mean to say, I'm happy to edit that out. To access the presentations, you could click on physicians, and then you can see where the presentations are on the hospital intranet. Okay, very good. So let's start with the first case. Let me just try this out. So the first case is, does this patient have decisional capacity to refuse an amputation? The patient is a 44-year-old male with schizophrenia, polysubstance use disorder, who was admitted after being found down, unresponsive, and in cardiac arrest. Patient required 2 hours of ACLS before return of spontaneous circulation, and tox screen was positive for fentanyl. Since admission, patient was found to have bilateral feet dry gangrene and deep tissue injury consistent with frostbite and likely vasopressor-induced ischemia of both lower legs. So procedures, assessments, and options. Podiatry performed debridement at the bedside. Vascular surgery was consulted for evaluation of possible bilateral BKAs. ABIs demonstrated adequate blood flow to the foot. There have not been any signs of infection from the wounds at this time, and per vascular surgery, note there is a low concern for systemic infection at this time. So the options that vascular surgery presented was, bilateral BKA now with closure and hopes of prosthetics in the future. Limb salvageability is high for this procedure, and ambulatory function in the future fair to good. Or because there's no active infection of the legs at this moment, one doesn't have to have surgical intervention now. One could merely treat with betadine to prevent spread of colonization of the dead tissue from transitioning to wet gangrene. However, one is unable to predict the exact time in which there'll be conversion from wet to wet gangrene, but likely to be within weeks to a few months. And there is a risk that the infection could spread quickly, and then the patient would need major limb amputation, probably above the knee amputation, and maybe have sepsis and resulting death. And ambulatory function might be very poor or absent if the patient lives from that complication. So the issue was whether the patient had decisional capacity. When asked about his understanding of his medical condition during a family meeting, the patient said, "I don't want an amputation. I could keep walking on my feet." And when discussed that this was unlikely, he said, "Well, I know people who got better. I can feel my legs are getting better, and if I pass out again, then maybe I'll do the amputation at that time." When discussing the risks of not amputating his legs, he states, "I'll call 911. He nods in understanding that he will most likely lose his legs if he doesn't get the amputation." Upon evaluation 2 days later, when asked about frostbite, he doesn't really know what frostbite means. He says his legs don't have any issues and that he just needs a walker to walk. He says he has been using a walker in the hospital. However, as per nursing, that is untrue. Upon further discussion about his wounds getting worse, he said he's not really concerned about that. So we had, he was evaluated by psychiatry, and I don't know if Dr. Forrester is on the line here to...
Yes, I'm here.
Okay, great. Instead of me reading this, why don't you tell us what you found upon your evaluation?
Yes. So in terms of his capacity to decide about amputation, part of what we need to look at is whether or not the person understands the nature of their medical issue, whether or not they can manipulate the information surrounding the proposed treatment plan, including whether or not there's significant risks to accepting or refusing the treatment, and also whether or not there are any other factors that are affecting the person's decision making. So for this particular patient, he, and as we've noted before, did not fundamentally understand what was going on. He didn't understand what frostbite meant. He didn't understand the severity of what was going on with his legs. And he continued to insist that he could walk and that the legs would get better, when it was clear from the documentation that the legs were beyond any point that they would sort of heal on their own. And actually, he was more at risk for auto amputation than anything else due to the level of the gangrene. So just based on that one tenet of capacity, he really wouldn't have had the capacity to decide about whether or not to get an amputation because he fundamentally didn't understand what was wrong with him. But then if we move on to the other aspects of how we determine capacity, The other things that were going on was that also this patient had ongoing hallucinations. He was at times delusional, and he was delirious after he woke up when he was found outside and had to be resuscitated. So we actually started him on antipsychotic medication to try to see if that would help to restore his capacity, but unfortunately it did not. And he continued to again insist that nothing was wrong, that he could walk, and he was PT attempted to work with the patient to try to demonstrate to him that he couldn't walk, and even after that, he continued to insist that he could walk. So he really could not understand what was going on. The other part of this was that the patient continued to say, well, I don't need any additional help. I'll just go back to the street. I'll continue to use drugs. I don't need any help. I don't need to take medication. I don't need to follow up with doctors. So there were many areas within which this patient really couldn't understand that he had a serious issue that was going on, or why a surgery was being proposed.
Okay, so basically lacks capacity to refuse the recommended BKAs. Okay, so as we continue on, medical team assessment, the BKA was recommended, but the patient kept on refusing, and one reached out to the mom, and basically she's was told all the information, and she said that she will think about the surgical plan and decide tomorrow. So she gave some past social history. He had a history of psychiatric issues in the past, and said that back in 2015, he was probably more social at the time. However, his entire life, he has been juvenile in his decision-making and rarely understands the consequences of his actions. And essentially, she kept on confirming that he doesn't have good decision-making, and she decided that ultimately it would be best to proceed with the amputation and for him to go into subacute rehab afterwards. She said she and the patient's brother would reach out to him and encourage him to agree to both the amputation and the rehab placement as well, rather than living on the streets. The medical team was concerned about having the BKAs performed in a patient without ongoing infection, so they called an ethics consult. I spoke with the patient about the amputation, and he said, listen, I really don't want my legs cut off. I would rather wait until they get infected and then have the amputation. But I said, if you wait, you would risk having a higher amputation and possibly death. And he said, well, I'll take that risk. Well, so in regards to the framework for ethical decision-making, here's the framework. One, you recognize that you actually have an ethics issues. Who are the stakeholders? Get all the facts, evaluate alternative options, make a decision, see what happens, and then reflect on the outcome. So essentially, so there's three options here. One, inquire with case manager regarding a potential discharge plan to a facility where he could be watched and for potential infection, essentially giving him his liberty not to have the amputation now, or discharge to a facility, or have the BKAs now. However, discharge to the streets is not an option. So, what to do now? So what I like you to do is use your cell phones, okay? Go to menti.com and put in the code 20421776, and I want to hear your opinion. Immediate surgery for BKA, or a period of watchful waiting in a skilled nursing facility, or unsure. What do you think we should do now? Okay, all right. 9 people have voted. Oh, the code is up here, 20421776. I think you could all see the code. All right, 21 voted. Let's have a few more. No one is unsure about this. Good. All right, why don't we get 5 more? I think we see a trend here. Okay, well, it looks like most people would say if he agrees to go to a skilled nursing facility, we won't have to do the BKAs now. Okay, keep on voting. We will not claim fraud with this voting mechanism, okay? All right, we count the votes. All right, very good. So let me, right. So BKA has been recommended, patient decline. The mother agrees with life-saving surgery in case of an emergency. Well, the outcome was essentially about a week later, he grew VRE in the blood culture, and essentially CT remarkable for left calf abscess, and vascular was recommending urgent surgery, and patient does not have the capacity to refuse. even though he still declines. Andrew, are you on the line?
Yeah, I'm here.
Okay, great. Tell us what was the process in getting him to surgery?
Sure. So
Yeah, go ahead.
one of our concerns at this point was that we weren't sure if it would be helpful to him to know ahead of time if he was going for the BKA or not, and we, through a kind of a group discussion between us and Vascular, decided, well, he should be aware that he's going to have this BKA, so we would tell him, even though it sounded like we technically didn't have to tell him because he needed the surgery regardless, now that he was bacteremic. So we came up with a plan with nursing that when transport was there, we would tell him that he was going to go to surgery. And we would have, we had an EKG prior, and we were going to give him Geodon if needed. And essentially, I went to the bedside, I talked to him, and I told him that it was time to go for surgery. And he was agreeable at that point, even though he had been kind of in denial throughout the entire process. He basically just said, I actually haven't been feeling well. And I thought that, if I just kept saying like I was feeling fine, it would just go away. So there was a lot that, just in that one moment, and only then, and not after surgery otherwise, that he just was agreeable and like understood, or seemingly seemed to understand that, he did need the surgery. But then, and we, obviously didn't need to give him Geodon in case he was going to need to go kicking and screaming, which he'd actually threatened to do earlier in the day, when there were suggestions that he might need to go to the OR. So that was pretty much kind of how that went, and it definitely helped. I think everyone involved in his care sleep a lot better at night, knowing that in the end he was agreeable to the operation.
Okay, very good. And he had a good outcome. Patient got accepted in a facility in Ellicott City, and the mom was thrilled with this facility, and patient left to rehab in a AMBO in stable condition. He left with all his belongings, and we also took out the IV. Okay, very good. Any questions about any aspect of this case?
Did the mother accept the preventive surgery before he became infected?
No, she was saying, let's wait until we have an emergency situation.
Okay.
Yeah, right. So are you asking if she had said, let's not wait, then she would be overruling whatever capacity the patient might be having?
What I'm saying is that he doesn't have capacity, didn't have capacity, and he couldn't accept the risk. If she was willing to accept the risk as the POA, then in fact that was the correct thing to do. I did not hear that she accepted the risk of waiting for him to get infected. I mean, we know that he could have died. So as long as she accepted that risk as the POA, then it was done right.
Right, yeah. The mom agrees with life-saving surgery in case of emergency, but non-committed to non-emergent surgery. So thanks for that clarification. Good. Any other questions? Okay. How long ago did this happen? Andrew, a few weeks ago, right? I think.
Yeah, this happened a few weeks ago.
Okay, good, great. Okay, very good. So let's move on. This next case is a PEG, ethically, medically appropriate for this patient. So patient, 71-year-old male, history of CVA, severe dementia, peripheral vascular disease, and prostate cancer, brought in by the family for a concern for decreased PO intake, came from the PCP office for labs and possible PEG placement for the decreased PO intake. Now, he was at university a few weeks previously for decreased PO intake and oral pain, and he had dental extraction, and patient was cleared for pureed foods but had trouble swallowing. This was at the previous admission, and palliative care offered hospice, but the family declined, and also the daughter was offered a PEG tube, but she declined at that time. Now, in the emergency room on this admission, patient noted to have a UTI, and per the patient's daughter, over the last 3 weeks, he has had poor PO intake, refusing to eat, and been pouching his food, but he's been taking all his medicines. We had a family meeting, and with the patient's daughter and the rest of her family, and the daughter was convinced that once her father gets the nutrient that he needs, he will live long. She stated that it would be very difficult for her to look back and realize that she could have helped him with the adequate nutrition. Outcome of the family meeting, all the other family members was in agreement not to have the feeding tube and to take the patient home and provide him with much needed comfort and dignity. However, the daughter is the decision maker and now would like to pursue a PEG tube. At this time, does agree with DNR/DNI. Now, an ethics consult was asked. Patient, I saw the patient. He was alert. He was awake, non-responsive, and fiddling around with his nasal cannula tube. Our analysis was essentially patient with severe vascular dementia, history of prostate cancer, for which he was receiving a chemotherapy agent, reports of poor PO intake, admitted with a UTI, poor PO intake might be due to recurrent UTIs. We got a pre-albumin, which was 8 and which was below normal and evidence of malnourishment. So we said, well, it's difficult to say that a PEG tube is ethically inappropriate, and if he has poor PO intake and there does not appear to be a terminal illness. Now, he had vascular dementia. Now, if you have a patient with Alzheimer's and you get to the point where an Alzheimer's patient needs an NG tube for feedings, the conceived wisdom about Alzheimer's patients is when a patient with Alzheimer's gets to the point where they need a feeding tube, the thought that the dysphagia is indicative of an end-of-life situation, and the conceived wisdom is not to put in a feeding tube for someone with Alzheimer's disease. So the summary of all the consultants is GIs said he would not be a good candidate for a PEG. The IR radiologist said while they do not recommend a PEG, they would, however, place one anyway. We ethics said, well, there may be concerns about the patient pulling out the PEG and suffering complications. However, a PEG tube could be offered as a treatment option. Patient was evaluated by speech. The swallowing study was normal, and he was recommended to continue with a puree diet with thin liquids. So essentially, what to do now? So I want to hear what you think in terms of what to do now. So that was the final vote. So now go back to menti.com, put in the code 20421776. Yes to a PEG tube, no to a PEG tube, continue with oral feeds, or maybe not sure. Okay. So let's see what you guys think. Oh, this is anonymous. Okay. Not that it needs to be anonymous, or maybe it does. All right, so let's have a few more votes. Oh, okay, one person not sure. Okay, very good. All right, so.
Henry, can you hear me? This is Chandana. Quick question.
Yes.
So do we have any idea if we know his wishes before his dementia? Do we know any advance directive or anything from the patient?
No.
Okay.
Good question. We don't know. So people who are voting for no to a peg tube, let's hear some thoughts about that, if anyone is willing. JH is raising his or her hand, so feel free to unmute yourself. Also, if you're saying yes to a peg tube, anybody wants to offer their thoughts?
I will go ahead, Chandana, again and speak my mind here. Yes to peg tube. This gentleman is getting chemotherapy for prostate cancer, and we are choosing not to feed him. I mean, ethically makes no sense. He's still under full treatment and care for his CA prostate. So either we do it holistically and give him the nutrition he needs, which is more than peg tube is for nutrition. It's not even medical care, in my opinion. That's all.
Okay, good thought. I mean, he's getting chemotherapy. Why not the 2 feeds? And he has evidence of malnourishment. Other thoughts?
I think this is Melita. I think if we're worried about him pulling the peg tube and that's why we're saying no, I mean, there are ways to help the patient. I mean, giving him an abdominal binder or maybe interim, at least giving him mittens so he doesn't pull the tube out. But, and that would be some of my thoughts.
Okay, all right.
This is Kokal. The abdominal binders as well as mittens are not allowed in the nursing home. They go against that. And I don't think the patient should get a feeding tube. I'm a gastroenterologist, but in looking at this guy who's malnourished, and only daughter is the one who's saying that he should get it. The rest of the all family members say no. And I think we need to put her in that situation. Would she go through that if this thing happens to her?
Okay.
This is Charity. And my comment was that if I understand correctly, the speech language pathologist said that the patient was able to get nutrition as in the form of pureed diet. So it's not that the patient is not receiving any kind of nutrition, but thin liquids and a pureed diet was confirmed for that patient. True?
Yes, but in the last few weeks, his prealbumin is low, meaning even though he's been cleared for whatever reason, he's not taking in the foods.
Was he not pulling
is TPN and PPN also an option for this patient?
Okay, that's a interesting thought. Now, he's cared for at home.
This is the problem, because if he's at home, he's not getting all the support, and somebody has to sit down with him and slowly feed him, whether it's Ensure or whatever is needed, because he can swallow. But unfortunately, somebody has to make sure that he swallows and he doesn't have any trouble swallowing. So we should try to have somebody with him and continue to try to feed him by mouth. And the PPI and TPN are not the answer, because if you put them, PPN first thing does not have enough nutrition, no protein, much, or it's just like a 5%. Other TPN is a long-term central line and all that. That's in risk infection, plus a lot of the other complications.
Okay, all right. Good thoughts.
Has the medical decision maker recommended the PEG tube?
The daughter is the medical decision maker, and she wants the PEG tube.
He's shown evidence of not being able to get in enough calories.
Right.
I agree that the PEG tube needs to be put in because, again, these type of patients can be very difficult to get them to eat adequate nutrition. And that's what it comes down to, is adequate nutrition. He's shown that he's not been able to do that so far.
Right. Okay. All right.
Hi, my name is Temi Akimbani. I'm a neonatologist. I'm from a totally different world from most of you. But I agree that the PEG tube, thank you. I agree that the PEG tube should be put in. This man is getting chemotherapy. I agree with the other speaker. His nutrition needs to be optimized. So it's either we're going all the way with him, or, we're not.
Yeah, good thought. Yes. Okay. All right. Very good. Thank you for your thoughts. So where am I here? So let's see what happens. So the outcome with IV fluids and treatment of his UTI, his appetite improved after further discussions with his daughter, and given his improved appetite, the daughter decided to defer the PEG tube. At this time, the patient was discharged to the care of his daughter with close primary care follow-up. So to be continued. I think everybody gave good reasons for and against the PEG tube. I think that there's no right answer, but more importantly, I don't think there was essentially either answer would have been a bad answer. And we'll see what happens with in the future, whether he continues with the improved PO intake. Okay. Any final thoughts? I actually think the issues with PEG tubes are more difficult sometimes than whether to forego other types of life-sustaining treatments. Okay.
Dr.
Right.
Silverman?
Yes.
This is David Riedel. I have a question. You laid out a scenario where in Alzheimer's disease, dysphagia is like a pre-terminal event, but what's the practical difference for vascular dementia?
It's
Seems
not
like
the same. Yeah, it's not the same.
Is it pathophysiologically, or just it's not as well established as in Alzheimer's disease?
Pathophysiologically. Two different illnesses.
Thank you.
Yeah, thanks for bringing that up. Okay. All right. Okay, good. So let's, third case. What are appropriate goals of care? Patient is a 47-year-old male, presented with facial swelling and periorbital swelling, and CT of the face obtained showed bilateral occlusions of the cavernous sinus, and other veins were thrombosed and diffuse cerebral edema. Hospital course significant for continued progressive cerebral edema, respiratory failure. MRI showed worsening of the cerebral infection, empyema, and new intraorbital abscesses as well as skull base osteomyelitis. Prognosis is very poor. So essentially, this patient has disseminated MRSA infection, including purulent sinusitis, cavernous sinus thrombosis, subdural empyema, left lung empyema, and jugular clots. The patient's POA is his aunt, and at a family meeting, there was a consensus for compassionate extubation. The aunt wanted her daughter to see the patient, which he did, and when the daughter came in, the daughter requested continued life support for another week. Multiple family members called in, and it appears that there is a lack of consensus among them. So essentially, what we have is a patient poor prognosis with overwhelming MRSA infection. Initially, the family or the aunt opted for compassionate extubation, but that has now changed, and the family or the niece is requesting continued life support for another week. Neurosurgical team believes that continued treatment is ethically inappropriate, and essentially they got an ethics consult, and we said the physician should determine whether treatment is futile as well. So, what are your thoughts about this? Either unmute yourself or say something in the chat box. So essentially, a compassionate extubation was planned on Friday. The niece came in and said, let's wait another week. I don't know why 1 week was chosen.
So the patient's aunt's niece is the one who did this?
The aunt wanted compassionate extubation, and the niece, which would be the patient's niece.
Oh, the patient's niece. Okay.
Yes, right, yeah. Said, no, let's wait another week.
Who is the POA? Do we have a designated decision maker?
Good question. There is no written declaration of who the POA is, and Maryland law says, guardian, spouse, children, and then everybody else. So they don't make a distinction whether it should be the aunt or the niece. Okay, Chandana, you want to say something?
No, sorry. I was replying to a chat query about previous case. No, nothing here.
Oh, I see. Okay, don't let me interrupt the chats. Okay. Other thoughts?
But here, maybe I missed something. Why was MRSA bacteremia deemed untreatable?
Okay, good question. So this raises the issue of, is diffuse infectious cerebritis what I had put on a previous slide for the ethical framework, get the facts. So what are the facts about diffuse MRSA cerebritis? Is it untreatable?
Right. So I think, Chandana, again, my thing would be, did he finish or did he get his full antibiotic course? And I'm not infectious disease, so I don't know if it'll be 21 days of IV antibiotics, 6 weeks. I do not know. But in my opinion, anybody should be, for bacteremia for which we have good antibiotics, some third generations, we should use all the bullets in our arsenal before we deem it untreatable. And we should treat it for the right length of time.
Okay. Dave, are you still with us?
Yeah, I don't think, I'm not sure that the bacteremia or the MRSA itself was non-treatable, but it seems like the consequences, which was the cerebral impacts, like the cerebral edema and what happened to his brain, I'm guessing is the consequences that were irreversible.
Okay, so
but not the MRSA itself shouldn't be untreatable.
Right. Okay.
I would like to second what Chandana said there. I have a little bit the advantage of the hindsight because unless there's a very similar patient, I just discharged that patient in stable condition to rehab from our regular neurology service, which goes to show that the statement that the prognosis is very poor may have been a little bit of a very bold statement early on when the whole situation was still a little bit too dynamic to be that certain of it. I mean, it's a 47-year-old without terminal illness per se, without significant pre-existing conditions to what I know. And I would certainly be, obviously if there's a decision by the POA, then that's what it is, I guess. But until there's really a somewhat prolonged period of waiting, and progressive edema that really makes one think that there's really truly no hope of recovery. I'm not sure that at that age, and again, without any per se irreversible cerebral damage, I'm not sure that anybody should throw in the towel prematurely. That's certainly something one could consider very carefully. And the 1 week is obviously totally arbitrary, but maybe it was just the idea to give it a little more time and wait a little bit. And I would actually say that in retrospect, that strategy worked out quite favorably for the patient.
Okay.
Who's the attending on this case? If it's the neurosurgeon, they've made a judgment that it's futile care. Someone's going to have to refute the neurosurgeon. If it's the attending physician, who's the ultimate decision maker, disagrees with the neurosurgeon, then it isn't futile care. But I thought I read someplace or heard someplace that the neurosurgeons determined the care to be futile.
Well, they thought it was ethically inappropriate, and maybe in the future, I like to explore further what that term means, but the ethics consult said, well, decide whether one thinks the treatment is actually futile. Other thoughts?
Yeah, I think ethically, it's certainly a decision that the physicians could make. Apologies that my camera doesn't work, Joe Moser. But I've had this conversation frequently over the last 5 years with UM's legal counsel, and interprets the Healthcare Decisions Act as requiring us to continue the support as long as discontinuing it would result in the patient's death, and other steps following that. But her opinion is it's a bad law, but no legislator has the appetite to revisit it.
Well, actually, the law says that if doctors think a treatment is futile and the family objects, then the family has the right to transfer the patient to another facility, and if with good faith efforts that cannot be done, then one could act on act on the judgment of futile care. But we'll explore. But I do agree. The law does a good job of defining futile care, but the procedural aspects is a little messy. Well, because of time constraints, let's. This is the mortality, morbidity of cerebritis, and over the past 5 decades, case fertility rate has decreased from 40 to 10%. Of course, that's all comers. So anyway, the treatment continued, and at one meeting with from the niece, she said that she is glad she chose to proceed with aggressive care because the patient is now more alert, oriented than he has been since being hospitalized. And just to at a follow-up family meeting, the niece decided to proceed with a trach and peg for the patient. Patient improved mental status, underwent the trach and peg, and patient was ready to go to rehab tomorrow. And so rehab note, when the patient was admitted to Umroid on March 16th, patient presents with dysfunction of the activities of daily living, and and he has severe neurophysical deficits, blah, 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 and he is appropriate for a course of acute inpatient neurologic rehab, where he will receive around-the-clock medical supervision, and essentially patient is appropriate for acute inpatient neurologic rehabilitation, and improvement is expected within 2 weeks. Patient able to tolerate therapy. There are no medical or functional reasons why this patient cannot tolerate 3 hours of therapy daily, 5 days per week. So we'll see what happens. Any final thoughts about this case?
I took care of this patient as well. This is Rachel. And I would kind of agree with the sentiment that perhaps the determination that this was futile care was a little bit premature. I think this gentleman is going to be left with some deficits, namely, it sounds like the ophthalmology team felt like he would be left with blindness secondary to this infection, but that doesn't mean that he's going to have no quality of life going forward. He's going to have an altered quality of life and have to make many adjustments. But, I think that the termination of futile care was made at a point where he looked very bad in the ICU and was perhaps a bit premature because he ultimately did start to improve.
Okay, thank you for those thoughts. Other thoughts? It's one thought I have is when you have no, for the lack of a better word, predominant decision maker, get all the input from all the family members. Now, having said that, I don't know if the aunt was the only family member at that time, but get the input from all the family members. Of course, sometimes you have to be careful of what you wish for, but I'm just referring back to the previous ethical framework and now reflecting on the outcome and see how it could help us for the next case. Final thoughts? I really appreciate everyone's thoughts. There's a question in the chat box asking for the ethnicity. Help us out here. Why do you ask that? Since you asked that, I did. Thoughts about that question.
He's African American. I'm not sure how relevant that is.
Right. Yeah.
There is a thought that this is Charity, and I asked that question, and I actually thought he was African American, and I'm not familiar with this case. But some of the things that were said, the niece that came and wanted to advocate and say, give him 1 more week so that we can see what happens, and was adamant about it, and her lack of trust in the system. That is a strong opinion of many in our area and in our region, unfortunately. And sometimes there's a thought that people will be dismissed and preemptively taken off life support based on ethnic background. And so I was just curious to know, because of some of the statements the niece had said, and the family's, the fact that he didn't have a POA, someone to make a decision for him and things like that, if that was impactful on the decision on whether or not to extubate him and take him off life support early.
Well, I think you're also saying that because of the level of mistrust among African Americans that they are more likely to disagree with a decision to stop treatment?
Yeah. Well, I think that this is something we face daily. And how do we help them know that we are doing the best for their loved one and providing all resources available for them and to support them through the process, that they can trust that we are not preemptively making these decisions, but are very thoughtful about these decisions regarding the care of their loved ones, how we can participate in that for them or encourage them in that.
Right. Yeah. So I'm glad you brought that up. Trust is a very important ethical value, and that's something that we need to be mindful.
Yeah, I would certainly hope that race did not play a role in that how the family was counseled. But obviously, we all have to be, these days more than ever, be very self-critical and wonder if we have biases that we are not even fully aware of ourselves. From systemic racism that certainly exists in our society, which I think at this point is widely acknowledged, and that's probably true for every individual healthcare professional also, whether we like to admit that or not, that we always have to critically question that. But even if race didn't play any role at all in this case, which obviously I would hope it did not, I think at the very least this is a very strong reminder of that we need to be humble with our prognostication, because as again, this patient was, as Rachel pointed out, is he impaired in his quality of life? Sure. But, the patient was communicating, non-verbally mostly because of his trach. But, I was the discharging attending physician on the neurology service. And, we have certainly seen patients much worse with an outcome that were not declared of very poor prognosis or hopeless in the middle of the treatment. So these potentially treatable conditions, I think, instinctively that niece or whoever it was actually made the right call there, that waiting a week and giving it a little more time. I'm sure there was nothing specific about the 1 week, but it seemed so irrational to us, and it's so easy to dismiss that. But her instinct to maybe he needs a little more time and maybe things might turn around turned out to be true. And all of us super highly trained and educated healthcare professionals got it wrong, right? When we said that he has a very poor prognosis and he will probably be brain dead or whatever, and lo and behold, he's not, right? So I think it's a good reminder that, and it's very different, obviously, if somebody has dementia or end-stage cancer or something that we know there is just really no hope, but to the best of our medical knowledge. But even based on these statistics that you showed us there, Dr. Silverman, right? I mean, it doesn't even seem like the statistics back up that very poor prognosis so easily. So maybe not everybody was even perfectly well informed of what the prognosis based on the medical literature even is. So, I think that niece, with her gut feeling, made the better call than we did as medical professionals. I think that's what it comes down to. So I think it's okay to acknowledge that and to always take a step back, regardless of race, and just say, well, maybe the prognostic. Remember how difficult prognostication is for somebody who's acutely ill. We may just get it wrong sometime, right?
Right. It's not an exact science, to be sure. I'm glad that this space provides a good, what I would like to call a moral space where we could have a good, healthy discussion about these difficult, complex patients. I appreciate everyone's willingness to share their thoughts, and that people feel comfortable to share their thoughts, because that's the only way we could progress as moral agents for the hospital. Any remaining thoughts? Well,
Dr. Silverman.
Yes.
Sorry, Charity, one more time. Thank you, Dr. Rayner. I really appreciate all your thoughts behind what you just shared. And I was looking in the chat, and I know that someone mentioned a comment about that last patient we discussed and how we need to remember we're in a pandemic and resources are low, and maybe we should let people go. That's and my stimulated thought behind it is I recognize that we are in a pandemic, and sometimes resources can be limited. But as healthcare providers and specialists, that we continue to do the best that we know for every patient, despite what resources we have at hand and the situation that we're currently in. It's scary. Thank you.
Right. Yeah. Thanks for bringing that up. There was a recent article about DNR, and I think the major issue in that article was not that we need to be more, well, what I'm trying to say is that not that every patient needs CPR in the pandemic times due to multiple reasons. However, one surely needs to be transparent with the conversations. I think in addition to trust, we talk about beneficence, autonomy, justice. I think equally important ethical values are transparency, accountability, and trust as well. The whole 9 yards. So, stay tuned for our next ethics rounds. I try to have this every month, so I'll let you know about the next one, and thanks for registering for this event. So
thank you very much.
Have a good weekend. Thank you. Thank you very much.